Welcome to this educational activity titled Immuno Oncology Virtual Cancer Committee. The faculty members who contributed to this program include Dr. David Penberthy, Medical Director of Radiation Oncology at Southside Regional Medical Center, Dr. John Somerville, Laboratory Director at Southside Regional Medical Center, Tracy Tatum, Director of Oncology Service Line at Southside Regional Medical Center, and Dr. Joseph Kim, President of Q-Synthesis. This educational activity will walk you through a virtual discussion that is occurring during a Cancer Committee meeting. The setting is Peace Memorial Cancer Center, which is a fictitious community cancer center located in the suburbs of the Midwestern United States. This is the main cancer center in the region, and it is located adjacent to the fictitious Peace Memorial Hospital. The nearest major metropolitan area is approximately 2 hours away by car, and over 1,000 new cancer cases are diagnosed each year. The top cancer diagnoses, based on the data that's in the tumor registry, include breast cancer at 23%, lung cancer at 21%, colorectal cancer at 12%, and prostate cancer at 9%. Throughout this educational program, you'll be hearing from different Cancer Committee members. The fictitious names of these members include Dr. Thorax, who is the thoracic surgeon and the chair of the Cancer Committee. I will play the role of Dr. Thorax. You will also hear from Dr. Myeloid, our medical oncologist, as well as Dr. Tissue, our pathologist. Mrs. Needle represents the Oncology Service Line Director. Mrs. Compass represents the Nurse Navigator. So we're now on this section of the program where we want to introduce the Cancer Committee. The Cancer Committee is now preparing to discuss some key findings as they prepare for next year. Next year, they're anticipating that more of their cancer patients will be treated with immune checkpoint inhibitors. And so in preparation for this meeting, several members of the Cancer Center have reviewed data from 2 recent quality studies, and we'll be talking about those 2 studies today. The first quality study is a study looking at biomarker testing, and we focused here primarily on patients with advanced lung cancer because they represented most of the patients receiving these immune checkpoint inhibitors. But we also have a second quality study looking at immune-related adverse events associated with immune checkpoint inhibitors. And this study involved patients with multiple types of cancers. So I think these 2 studies will allow us to review how we're doing things within our own institution, and then talk about ways we can make improvements as we plan for next year. Let's go ahead and get ready to dive into quality study number 1, which is the biomarker testing study. I'd like to ask Mrs. Needle, as the Service Line Director, to tell us why is this important for us to talk about as we prepare for next year. So, Mrs. Needle?
This recently published article points out the rapidly evolving state of molecular profiling, clinical practice standards, and treatment development. So it does point out the need for these metastatic patients with these solid tumors to have a broad molecular profiling. So one, we don't miss anything. It can give us prognostic data as well as treatment data. Other points that it really makes is some of the differences in the methodologies for these testing, which can make it critical that we're not comparing new testing with old testing or comparing different laboratory testing to each other. And then the third point that I'd like to make is that the pathologists are really going to be the people that ensure the quality of these specimens that get sent. That will also affect the quality of the results that we get.
Dr. Tissue, as the pathologist, tell us what you found when you conducted this quality study.
Yes, we conducted a study of 87 patients from last year, all of whom had stage 4 adenocarcinoma. These are mostly diagnosed on small biopsies, endobronchial or IR-guided biopsies, although there was occasional resection specimen or cytology cell block that we used for this. 53 of the 87 patients, so 61%, had complete biomarker testing, which at that time was EGFR, alpha-ROS1, BRAF, and PD-L1. These are mostly done as separate tests at this time, although many more of the tests are being done by next-generation sequencing. Amongst the 34 patients who didn't have complete biomarker testing, we had some QNS insufficient specimens, so 7 patients had partial testing, 11 patients had no testing performed for the same reason, and in 16 patients, the tests just weren't ordered. 2 patients had cell-free circulating DNA assessed liquid biopsy in a specimen that was drawn in the oncologist's office.
Dr. Tissue, can you just comment real briefly, as well as Mrs. Compass as nurse navigator, if you could also comment, are pathologists receiving the results from these cell-free or circulating tumor DNA tests when they're ordered?
No, we aren't actually. The nurse navigator has access to that, and we could obtain that information, but that's not sent separately nor placed in our pathology the medical record file.
What has made this study possible is the nurse navigator having access to different electronic medical records. So the medical oncology office, she can access those records, as well as the primary care office, the hospital itself, and the radiation department.
Of the 87 patients we had who had stage 4 non-small cell lung cancer, 18 received targeted therapies, 17 with an EGFR inhibitor and 1 with an ALK inhibitor. We had no patients who had ROS1 or BRAF mutations. 39 patients were treated with an immune checkpoint inhibitor, some with additional chemotherapy, and all of them had had PD-L1 testing by immunohistology. And 25 patients received cytotoxic chemotherapy, 23 of which did not have PD-L1 testing. And 5 patients did not have any therapy, including 2 that were referred to hospice and 3 patients that refused treatment.
Dr. Tissue, tell us about the latest updates from the NCCN. What are the guidelines around biomarker testing for these patients?
Well, for all non-squamous non-small cell lung cancers, testing with PD-L1 by immunohistology and EGFR, ALK, and ROS1 and BRAF is recommended. That includes non-small cell carcinoma not otherwise specified. But in those cases where it's unclear or there could be a mixed histology, those 5 markers are suggested. For squamous cell carcinoma, we are currently routinely only performing the PD-L1 by IHC, but there is some consideration for using EGFR, ALK, ROS1, and BRAF in some of the specimens, especially if they're very small or if it's not completely clear that it's a pure squamous.
Thank you for that brief update.
I'd like to take a moment just to describe for non-small cell lung cancer, the FDA has several approved targeted therapies. And as an example, if you have the sensitizing EGFR mutation, there are 5 different medicines that are currently FDA approved. If you have the ALK rearrangement, there are 5 additional medicines that are approved, the ROS1 rearrangement, ceritinib, crizotinib, and entrectinib. If you have the V600E BRAF mutation, there's a doublet called dabrafenib and trametinib that are FDA approved. And for the NTRK gene fusion, entrectinib and larotrectinib are both approved. Now, this is just a simple snapshot for non-small cell lung cancer, but this is a list that's rapidly evolving over time. And so do not consider this to be static and state-of-the-art for long.
Thank you for that summary, Dr. Mylod. Let me remind the committee of where we stand when it comes to FDA-approved immune checkpoint inhibitors for non-small cell lung cancer. So as of the time of this recording, there are currently 4 immune checkpoint inhibitors. 2 of them are PD-1 inhibitors, and 2 of them are PD-L1 inhibitors. And out of these 4 agents, only one of them has, according to its FDA label, depending on its indicated use, only one of them has a PD-L1 companion diagnostic testing requirement, and that's for pembrolizumab. And it's done in such a way where you get a score called a tumor proportion score. And it's the number of PD-L1 positive tumor cells divided by the total number of PD-L1 positive plus PD-L1 negative tumor cells. And then that's multiplied by 100. I know we're going to be talking a little bit more about PD-L1 in just a moment. So let's move on to this other topic, which is around liquid biopsy. Dr. Tissue, give us a quick update on the latest science and the evidence according to the NCCN guidelines around the use of liquid biopsy.
Well, the NCCN specifically states that if at all possible, the liquid biopsy should not be used in lieu of a tissue diagnosis. As we noted in the study previously described, the vast majority of our patients, we were able to get much, if not all, of the testing performed on a biopsy, although there were some specimens that were inadequate for complete testing and a few inadequate for any testing whatsoever. The The recommendation is, if possible, to obtain a second tissue diagnosis, but if that's not possible, then cell-free DNA testing can be used. And although it's highly specific, it does have a relatively low sensitivity with about a 30% false negative rate. And if that's the case, one would be compelled to repeat a biopsy. However, the standards for analytic performance for the test have not been established, and there are no guidelines that exist regarding the recommended performance characteristics. In some circumstances, such as if the patient is medically unfit for the initial biopsy, it may be possible and advisable to perform a liquid biopsy to see if comparable results can be obtained. If, after initial confirmation of the diagnosis, there is insufficient material for full molecular analysis, then one can defer to liquid biopsy, but still, at that, for all further treatment, it's recommended that an additional biopsy be performed.
Dr. Tissue, tell us about the latest updates and recommendations around PD-L1 testing.
Well, as you know, we're doing PD-L1 testing for a number of tumor sites, not just for lung cancers. But there is a Category 1 NCCN recommendation for lung cancers that PD-L1 testing by immunohistology be performed before first-line treatment in all metastatic non-small cell lung cancer. There are multiple different assays available using different antibodies for each of the immune checkpoint inhibitors. The definition of a positive PD-L1 test does vary depending upon which biomarker assay is used. We see results of less than 1% not expressed all the way up to 80 or 90% in some of ours. It's not really an optimal biomarker, but it's the best biomarker we have there for patients who are being treated with PD-L1 therapy and also PD-1. And it's a continuously variable, so that the definable individual cutoff is a rather artificial concept. Even though we do perform PD-L1 testing on all patients with new metastatic non-small cell lung cancer, some of those patients are treated even if they are non-expressors of PD-L1.
Thank you for that summary. Dr. Myeloid, as the medical oncologist, tell us about tumor mutational burden.
Well, tumor mutational burden is this emerging marker for different types of tumors. And here we have a slide that shows an active area of research. This has different studies that are looking at tumor mutational burden, specifically in non-small cell lung cancer.
So it sounds like this is definitely an area that's emerging, and it's possible that by next year, the use of this biomarker could change. So it's something we will have to keep a real close eye on.
Tumor mutational burden, TMB, is also called mutational load, which measures the total number of mutations per coding area of a genome. Oftentimes, this is reported as mutations per megabase, and 1 megabase is 1 million DNA base pairs. TMB is being studied as a predictive biomarker for immunotherapy. NCCN guidelines for non-small cell lung cancer list tumor mutational burden as an emerging biomarker that may be helpful in selecting patients for immunotherapy. But the problem is there's a need for robust analytical and clinical validation, and there's lack of standardization for TMB calculation and reporting.
As a cancer committee, let's discuss the findings from this first quality study and talk about how this impacts our organization. Where does this put us as a community cancer center in regards to standardizing biomarker testing processes? How do we ensure that our radiologists, pulmonologists, surgeons, and others are providing the best samples for testing? And then do we really know as an institution how we should be using liquid biopsy? Do our oncologists, our nurses, do they all know where to use this and what the guidelines recommend? So I'd love to have some discussion. Let me start with Dr. Tissue as the pathologist. What are your thoughts around some of these topics?
Well, we work hard in conjunction with the interventional radiologists to try to assure that we have adequate tissue in a single procedure. That is, if they do a directed biopsy, transthoracic or whatever, we make imprint slides, which we look at immediately and attempt to determine the adequacy. Occasionally, we'll even take a small portion of the tissue and do a frozen section and be sure that they have sufficient tissue for diagnosis and for molecular testing. That, in most cases, assures us of adequate tissue. Unfortunately, when the pulmonologists do their endobronchial biopsies, we rarely have the opportunity to assess the tissue beforehand, and we get our tissue in formalin and often evaluate the slides the next day. There may not be enough tissue for the molecular testing, and sometimes, obviously, not even enough for the initial diagnosis.
Thank you, Dr. Tissue, for those comments. Dr. Myeloid, as a medical oncologist, do you feel like we're doing the right thing in terms of identifying which patient should be tested, which test should be ordered? Are we testing at the right time? What are your thoughts?
We're actively looking at this in our cancer center just because We want as much information for each patient as we can get, but oftentimes at the time of biopsy, we don't have the information as far as what the stage of the patient is, et cetera. And so we're having slight difficulty determining who should get the test ordered initially. In an ideal situation, everybody would get the test done, but in a real-world situation, there are costs associated with this, and so we're trying to be selective with the ordering of these relatively expensive tests. So as a service line director, have you had any chance to speak to the interventional radiologists or the pathologists about when they would like to get these tests ordered? As a medical oncologist, I want it on everybody, but I realize that may not be realistic.
So I think that some of the challenges we've identified are kind of exactly what we're talking about. Having this expertise based on national guidelines to say this is exactly who should be tested, these are exactly the tests that we should be doing. You know, staffing plays a role in all of this, having patients getting in quickly and then seeing these specimens, and then, you know, our technologies that we are able to use to obtain these biopsies and, you know, working with our thoracic surgeon as well.
So we're trying to speak to our pulmonology colleagues as well, because oftentimes the patients are initially seen by not oncology professionals, but pulmonologists. And so if somebody has a high level of suspicion, we're suggesting that they order the next generation sequencing so we have the information in a timely manner. Oftentimes I will speak to my patients, and when I tell them I'm going to order another test and I need 2 weeks turnaround time, they sometimes give me a little bit of pushback because they would like to initiate therapy earlier. However, I want to initiate the appropriate therapy at the appropriate times.
And it sounds like the science as well as the guidelines around all these testing recommendations are constantly changing. So as a cancer center, we need to make sure that we're reviewing what we're doing and really allowing pathology to play a key role in leading in this area. Let's move on to some ideas. What are some things that we can do as we think about next year, knowing that we're going to prioritize immuno-oncology as a real goal within our cancer center, and also anticipating that more patients with cancer are going to be treated with the immune checkpoint inhibitors? Dr. Tishu, as the pathology director, what are your thoughts in terms of what can be done to make sure that our cancer center is better equipped and prepared for next year?
I believe the transition to next generation sequencing is helping us from a number of perspectives. We're having fewer specimens that are inadequate in terms of tissue volume, and the turnaround times have improved enough in the last years that the time to receive the results is comparable to when we previously ordered individually.
I think as the director of a program, I'm going to want to track everything, turnaround times. And, you know, I think looking at maybe reviewing these patients at a specific tumor board could be helpful, because then we can look at all the way from ordering to how they were treated. And even if they become metastatic, we can follow them for that. You know, there's the option maybe of having a committee that looks at all this patient data that are all specialists in this immuno-oncology field, or even a multidisciplinary clinic. So all these physicians that are specialists can see these patients before we even move forward with testing and treatment as well.
Dr. Tishu, on the pathology requisition form, is there a check block for stage 4 or suspicion for metastatic disease? Would that be helpful for you?
It certainly would. Sometimes our reference laboratory contacts us and asks us to document that the patient has stage 4 disease.
Mrs. Compass, as nurse navigator, do you feel like there might be a role where navigators can help to coordinate the care around biomarker testing?
Yes, I think tracking the people that are tested and identifying the people that aren't getting this testing and helping to identify those and facilitate the testing and the treatment could be a big role for the navigator.
I think we need to impress upon all of our medical colleagues just about what's happening in the oncology space. The treatments are rapidly evolving, techniques are rapidly evolving, and so timeliness and communication is going to be critical for us to remain at the forefront, cutting edge in our community oncology program like we have.
This is such an important topic for us that I'd like to suggest an action item for the committee. This is for the pathologist, Dr. Tissue, to form and lead a biomarker testing task force, where the task force will establish and identify which biomarkers will be tested, as well as outline who's going to order the tests. And then from there, we can also structure educational conferences and meetings such as journal clubs and increase the overall communication as well as collaboration among all the colleagues. Dr. Tissue, what are your thoughts about this idea?
That sounds like a good plan to me, and we've been thinking about implementing some of these for quite some time.
Do you have a sense of who you would like to join you on this task force?
Certainly surgery, and we have a single thoracic cancer surgeon here, radiation oncology and oncology. We have 5 oncologists at our facility, along with nursing.
So we'll plan to follow up after this cancer committee meeting, and then we look forward to hearing from you as you work with these colleagues to establish the task force and come up with some action items for us to review and discuss at our next meeting. Let's move on to our second quality study, which is the one focused on immune-mediated adverse reactions. So for this one, I'm going to ask Mrs. Compass, our nurse navigator, to present this quality study and share what did you find as you reviewed the data. Mrs. Compass?
Sure, thank you. Before we present the data, I would like to just bring your attention to the box on the right hand of the slide and review the grading of these adverse reactions just briefly. Grade 1 are these mild, potentially asymptomatic patients. Grade 2, these patients have moderate symptoms, but no invasive interventions usually are indicated at that point. Grade 3, these people are severely, significantly affected and potentially life-threatening. And then grade 4, these are the urgent intervention patients that have life-threatening symptoms. So last year, over 300 patients were treated with immune checkpoint inhibitors. 18 patients developed serious, the grade 3 and 4 immune-related adverse events, requiring them to visit the emergency room and or be hospitalized. 8 of these cases were a pneumonitis, 6 of them were colitis, 3 a hepatitis, and 1 case of hypophysitis. 1 patient had such a severe pneumonitis and another patient had a severe colitis that they did pass away when they were in the hospital. Among the 18 patients who developed these serious immune-mediated adverse reactions, 10 of them, which is 56%, did receive care that was consistent with the guidelines. 8 patients, which is 44%, did not receive such care. So if we identify gaps in care, 3 of these patients who presented with the signs of the pneumonitis were initially prescribed antibiotics, but were not given the steroids. 5 of the patients didn't receive the correct dosing of the steroids.
Thank you for sharing that. It seems like we've got quite a bit to discuss here and certainly some room for improvement. Dr. Myeloid, tell us about these IRAEs or immune-related adverse events and why they're so important.
Sure. Just as an example, let's talk about some specific immune checkpoint inhibitors, such as the CTLA-4 inhibitor ipilimumab, the PD-1 inhibitors, nivolumab, pembrolizumab, PD-L1 inhibitors, atezolizumab, avelumab, and durvalumab. So all of these immune checkpoint inhibitors are associated with toxicity profiles that are distinctly different from cytotoxic chemotherapy or targeted therapies. And these adverse effects may affect multiple organ systems at one time. They may have a delayed onset, which is critical for the other medical staff to understand, and they may be inflammatory or autoimmune in nature. Adverse effects are most commonly seen in the skin, in the GI tract, lungs, and endocrine systems, the thyroid, the adrenal system, pituitary, musculoskeletal system, renal system, nervous system, hematologic, cardiovascular, and ocular systems. One of the important points that was alluded to earlier is the delayed onset, and a patient may accurately report if they present to medical attention with some symptom that they are not on any sort of systemic treatment. That may be accurate, but if they were on it within the past 3 to 6 months, they may be experiencing an immune-related adverse event related to the medicine that had been given previously. And so our medical staff needs to be educated in that possibility and have a high index of suspicion in any of the patients that they're seeing in a primary care office or in an ER especially. This is a great example of one of the most serious adverse events that can happen with immunotherapy. So pneumonitis, it's defined as focal or diffuse inflammation of the lung parenchyma. Typically, it's identified on CT imaging, but there's no pathologic or radiographic features that are pathognomonic for pneumonitis. And so again, you have to have a high index of suspicion. If they're short of breath, if they're having difficulty maintaining their oxygen saturation. And so we typically work them up for pneumonitis with chest x-ray, CT, pulse oximetry. And if they have mild symptoms, grade 2, grade 1, we may just monitor them. But grade 2 or higher, we have very specific guidelines for how to address that. We can do, all the typical things, looking for infectious etiologies. We do nasal swabs, sputum cultures, sensitivity, blood cultures, urine cultures, etc. But if they have severe symptoms, we need to discontinue the immune checkpoint inhibitors. We treat empirically with antibiotics as well as steroids, and there are different steroids and at what dose. There are oftentimes cards that are available to steer the clinician into the appropriate dose of what steroid they're choosing to use. Sometimes, if the symptoms are relatively mild, you may reinstitute the immune checkpoint inhibitor if their symptoms have resolved and if they're on a relatively low dose of the steroid. But we have to monitor them until they are clinically resolved. So while they're being monitored, we get lots of people involved. You have pulmonary involved, infectious disease involved, and so this requires a lot of resources from not just the oncology department, but also other departments within the hospital. And periodically, patients do need to be hospitalized if their symptoms warrant that, because some of these pneumonitis toxicities can be fatal.
Mrs. Compass, tell us about the broad-based recommendations around the management of these immune-related adverse events, and what do nursing staff need to know, whether they're the clinic nurses or the infusion nurses, what do they need to be aware of?
So this really good article from the Journal of Clinical Oncology kind of just described a lot of this for us. Some key recommendations out of that article are we need to make sure that these patients and their family members are receiving this education about the mechanism of action of these immunotherapies, the possible side effects, and they need to receive this information not only initially but through treatment and through survivorship, because they are at risk for these side effects for the long term. We also need to be sure that there is a high level of suspicion for new symptoms, but also for symptoms that are ongoing or maybe worsening some. We really need to be paying attention to those. There are recommendations that are specific to the grade of the adverse event. In general, if it's a grade 1, you can continue with your immune checkpoint inhibitor unless it's something neurologic, hematologic, or cardiac. If they're a grade 2, we want to go ahead and hold that immune checkpoint inhibitor until the symptoms regress down to grade 1 or less. And then a steroid also may be prescribed for these patients that have a grade 2 toxicity. When we get into the grade 3 toxicities, we absolutely want to hold these checkpoint inhibitors. We do want to give the steroids. If the symptoms are not improving, we can also add more medication like a Remicade to see if we can help with this autoimmune issue. And then grade 4 toxicities, this warrants just a permanent discontinuation of the drug itself, unless it's an endocrinopathy, which can be controlled with hormone replacement.
Mrs. Needle, as Oncology Service Line Director, what are your priorities and thoughts around what we can do as a cancer center?
Actually can take us into our next slide about some practical applications for institutions managing these things. And so number 1 on the list is educating our patients, whether this be with like a visit summary, a pocket card, just making sure they have that information and then they can take that with them when they present to a provider. It's important that we're able to identify patients that are receiving these immunotherapies and communicating that information, whether we can do that through our shared EHR, patient portals where they can access that information themselves and, communicate that themselves. We really need to utilize our nurses, so our nurse educators and nurse navigators, to be able to communicate this information between providers. Having an identified physician champion or expert in this field could help guide the whole system and really the whole process. There is the opportunity to create some pharmacy order sets or guidelines for the patients for initial management of these toxicities, but then also for the patients that are going to be refractory to the steroid treatment. We need to have some guidelines how to progress with their treatment. I did mention implementing, a tumor board or a lecture series or a journal club so we can get this information disseminated. Looking at research, we don't have a infrastructure for research at this point, but I think maybe putting things in place that will lead us to help collecting more of this data and participating in research that looks at these toxicities would be helpful. Engaging our community oncology practices in being part of this process, sharing the information, communicating, and hopefully one of them also being the expert on this topic. And then collaborating with our non-oncology subspecialties should probably be number one. We have, our emergency rooms, we have our primary care doctors, hospitalists, we have pharmacists, our GI specialists, pulmonary, endocrine, nephrology, radiology. So we all really kind of need to work together to recognize these autoimmune consequences of this medication.
Absolutely. This is definitely something really important for us as we think about next year and anticipate that even more patients are going to be treated with these agents. Now, as the Cancer Committee gets together to discuss these issues, I'd love to hear from Dr. Myeloid first. What are your thoughts as a medical oncologist around what we can be doing? And then after you give your comments, Dr. Myeloid, would love to hear from Mrs. Compass as a nurse navigator. How do we better identify patients? How do we make sure that patients are being treated appropriately? And then how do we ensure that proper coordination of care is occurring?
First of all, I just want to state that I'm incredibly optimistic about the future of oncology as a result of this new development in oncology. The Nobel Prize was awarded to the people that developed the Immuno Oncology, and the field is really exploding, and we are seeing results now that we have not seen before. So it's really transforming the field of oncology, and everything you have stated as far as the numbers of patients are likely to increase over time. So it's important for us to understand this and then also to promote the information to our medical colleagues, the non-oncology colleagues, so that they are aware of what's happening in oncology. So oncology is rapidly transforming from a scary diagnosis to kind of a disease of chronic illness and managing it over time. And so I think it's going to be important for us to identify the patients that need these treatments and then manage their symptoms and their toxicities. And so it's just an exciting time in oncology.
And I might just have a little bit more specific, but it's in line with exactly what Dr. Myeloid said. I think that we do need to really work with our non-oncologic providers in making sure they have the education to identify these toxicities, assessing how our patients are being educated, and identifying any knowledge gaps among nurses, because if they don't have the information, then they can't give it to the patients. Reviewing and updating our current telephone triage system to make sure that anything suspicious kind of gets priority in the callback and in the, getting patients to come in and be seen. And then developing any clinical treatment pathways would be helpful so we can actually navigate these patients from beginning to end and make sure they're getting to the physicians they need to get to. And I don't know if quick reference guides like to grading or to treatment or just identifying these drugs, a drug reference, would be helpful to the nurses and the non-oncologic providers as well.
I think patient education is critical. We have a lot of patients who are not particularly well educated and may not have access or the ability to research the symptoms that they may be having. I would assume that the oncologists provide a significant amount of information to the patients at the time they receive immuno-oncology therapies. But as Dr. Myeloid mentioned, these complications can occur many months after the medication is being used, and they may not be aware of that. So I think the patient education is a critical component of this.
So we have talked about within our own institution of having a little toxicity team literally go to different departments, different nursing floors, the ER, and having just a little in-service of a 10 to 15 minute thing explaining some of the changes that are happening. And we found that that's been a very effective way to raise awareness of what's happening in oncology.
Mrs. Needle, what are your thoughts as service line director?
I feel like case-based education is the most helpful because then those patients kind of stick out in their minds, and when they come across another patient that's kind of similar, they're like, oh yeah, and can remember the education that they've received. And then as far as nursing, I have found that a poster sort of presentation is good, and that you can leave the poster there in their break room, because it's hard to get everybody in one place at one time, especially focused. Those are kind of my plans.
How about in terms of being more effective with patient education? How do you feel oncologists and our nurses can do a better job, especially since these agents are so different from traditional chemotherapy?
I think getting face-to-face with the patient, do you feel comfortable with giving the information to the patient if you aren't comfortable with the information yourself? So I think we do have a few things that we can address on our end to help those nurses better deliver the information.
And quite frankly, most of our oncologists consider their roles nowadays to be an educator role. You know, we're trying to educate the patients on why they need a specific therapy, educate the families, and then educate them on the possible outcomes and adverse consequences of these therapies. And so we allow a little extra time for that educational process because everybody has a different bandwidth. So sometimes people are completely informed about it, and other times this is the first time they're hearing about it when they step into an oncologist's office.
So it sounds like we have a potential action item that we can explore for next year around this topic of immune-related adverse events. The idea is to assign our nurse navigator to form and lead a tox team or a task force, an IO toxicity task force, to assess how patients are being educated and to look for ways to improve that education, to perhaps provide in-services to the nurses, as was mentioned earlier. And then what else can we do to train our emergency department staff, as well as develop treatment pathways for these things? Does this seem like a reasonable course of action for our cancer center, Mrs. Compass?
Yes, it does.
We just need a few engaged individuals to be willing to take this on, and I think we have them. We have an engaged medical staff and an engaged oncology department, and like I said before, is an exciting time within oncology.
Absolutely, and I'm sure that things will continue to change as we treat more patients with these agents, as more data emerges, and as we know how to use these agents better, we have to adapt and evolve as well. So we've covered two really important topics around immuno-oncology, and within this multidisciplinary setting of a cancer committee, we've talked about some ideas on what we as a cancer center can do. To summarize, we know that there are many advances in immuno-oncology, and we're probably going to treat more patients next year. So we really have to make sure that as an institution, we're doing the best around biomarker testing, PD-L1, but also some of the emerging markers, and then also looking for mutations and molecular alterations that may lead to targeted therapies. We also certainly have to focus on this topic of immune-related adverse events. So keeping up with the latest science, updating our own institutional policies and procedures, these are certainly really important priorities for us.
I think you hit the nail on the head. We need to remain flexible and kind of aware of the changing landscape. And so I think ongoing education is critical in this field.
I think continuing to evaluate quality and monitoring that is important.
I believe the molecular testing is changing as fast as anything. But again, I believe that next generation sequencing is going to help us a lot because many of the new abnormalities that are being detected as being significant and potentially treatable are already in the very large panel there. So we don't need to continuously add additional tests as we have over the last couple of years. And even a couple of years down the road, tests that are being done as part of the NGS panel that are currently not valid will already have been done. So a patient could be treated without additional testing.
With the rapidly evolving immuno-oncology landscape, with over 3,000 clinical trials, I'm really hopeful that the software systems help determine optimal care. And so I really think next generation sequencing, targeted therapies, and profiles will help direct oncology to the appropriate care at the appropriate time.
We really have an opportunity to make sure that patients are receiving optimal therapies that reflect the latest evidence.